Welcome. We're glad you're all here. It seems like we have folks from all around the country, as well as some good showing from right here in Missouri, and some from Missouri too. So we are, as you heard from Sandy, we're nonprofit, nonpartisan, and the discussion tonight is really not going to be about politics or about policy. It's going to be about the pragmatics, the reality of the decision that either you or someone in your family or a close friend of yours has to honestly make about how you want to approach um, Medicare. So there's a lot of things we could talk about policy, but I think at the end of the day, cutting to the chase, what we're going to conclude from this discussion is that it's really the decision that you have to make about this is really personal. I'm not going to tell you one answer that will make sense to fit for everybody's situation and circumstance, but my goal tonight is to help you sort of understand the decisions that are before you. So that's kind of the goal. But first, I want to introduce you to my mother-in-law because I just bear with me. I just like looking at her picture. Sadly, my mother-in-law passed away a few months ago, so this is sort of historic rather than so much current. But I did have her permission to tell you this story, and it's highly relevant to tonight's topic. So Ma, living in Florida, when she was about 14, 15 years ago, developed the symptoms of a pretty severe heart disease, severe enough that she probably wouldn't have lasted but a few more weeks had it not been treated. It wasn't standard sort of heart disease. It was a very uncommon thing called hokum, which is frankly rare in somebody in their 80s. So she had this really uncommon version of a heart disease in her 80s. Nobody in Florida, she lived in Florida, as I mentioned, nobody in the state of Florida, we weren't able to find anybody that had any particular experience treating hokum, her cardiac disease, in somebody at her age group. So, it's a hard thing to treat. You want to make sure you get somebody good. It turns out that St. Louis, where I live, where Consumers Council is got a lot of activity, um, um, St. Louis has one of the three centers for the country here at Washington University that focus on treating this disease in older folks. So we flew Ma from Florida here to St. Louis. She spent, I don't know, I think it was about 4 or 5 days in the hospital getting arguably world-class care for this condition, spent a few weeks recovering, and then went back home to Florida. And that was, I think, about 14 years or so before she passed away. And she did great. She had two orthopedic surgeries between then and her passing, and ultimately that had nothing to do with the cardiac thing that got really successfully treated. Why am I telling you this? Because she has or had Medicare, and she had Medigap, and we'll explain what that means. But I'm going to call it traditional Medicare, and I want you to understand what that word means. So the tradition of Medicare essentially was created in 1965, and it had Parts A and Part B. Part A, as you probably know, for traditional Medicare, it takes care of most inpatient things, and Medicare Part B is mostly outpatient things. So she had that, which is quite different from Medicare Advantage, as we will explain. And then she also had Medigap, which was pretty important. So because she had Medicare, she could go to almost any doctor in the country, and really, I think, any hospital in the country. And as she did, I'm the person who kind of managed a lot of that for her, and I never called Medicare for permission. Didn't have to, get prior approval. She didn't pay a penny. I mean, she literally didn't pay a penny for any of this. And then when she went home, over the next several months, there was never a surprise bill, as we know happens far too often. So it was from a health insurance point of view, it was terrific, and she really relied on it for all of her life, and since 65, and trusted that it would be there for the rest of her life. But if you tried to mess with her Medicare, you would have to deal with this version of my mother-in-law, and I confess I have at times, and you don't want to, so you don't want to do that. So what the interesting thing is that not a lot of people, and not even seniors, know the difference between what we're talking about between Medicare and Medicare Advantage. Even seniors who are in one of these programs don't know the difference between the two. And despite not knowing the difference, most seniors, a strong majority of seniors, don't want to have anything happen to Medicare Advantage, even though they haven't yet quite understood what it is. And so that's my goal tonight. My goal tonight is to help you make a well-informed personal decision about this fork in the road for you. So first, what's traditional Medicare? There's the little precious red, white, and blue cards that we get. So we pay our taxes. Federal government gives us our precious red, white, and blue card, and then we go to whatever doctor or hospital we want to, and Medicare pays the doctors and hospitals directly with no insurance company popped in the middle. It's almost as simple as that cartoon, not quite, but almost as simple as that. But then Medicare Advantage is quite different. It is quite different. So again, we still pay our taxes largely. And then interposed between Medicare and physicians or hospitals are insurance companies, largely the same insurance companies that often do a lot of employer-related insurance. So the federal government instead pays the insurance companies, and then the insurance companies pay the doctors and hospitals. So the insurance companies are prepaid before you get any healthcare delivered. The insurance companies are paid a flat dollar amount per person that's enrolled in there. More if you're sick, supposedly, and that's in, but they're paid a flat dollar amount every month that you're in their version of Medicare Advantage. And then, of course, they pay doctors and hospitals from money that is sitting in their account. So they're not eager to do that. It's a little bit more complicated than this in that they actually then tell us, this doctor and not that doctor, this hospital and not that hospital. So it's more complicated. And one of the main things that is worrisome is that you can't go to any doctor or hospital. In fact, nearly 12 million people in Medicare Advantage are limited to fewer than a third of the physicians that are in their county. An awful lot of the doctors are cut off, or you can't go see if you have Medicare Advantage. And certainly that's true in your county, as you can see here, but it's also really true if you go out of the area. If you spend 3 months in some other part of the country, chances are your Medicare Advantage insurance would be like most employer insurances and only cover you for emergencies and not cover you for maintenance things, and certainly make you pay more if you're going outside of their network. So the first difference is the size of the networks. Another difference is Medicare Advantage companies introduce managed care type tools, HMO type tools, prior authorizations and related things that we'll explain. Because they're prepaid, they don't particularly want to attract you if you're healthy, if you're sick, because then you cost more. So they have a bunch of strategies designed to attract healthier people. Their complexity is pretty expensive, so we'll talk about that a bit. And ironically, they've actually persuaded the government to pay them more per person. They were created with the promise in 2003 that they would improve the health of people in Medicare. And by improving the health of people in Medicare, they promised that they would be able to lower the cost of health care. They quickly figured out that wasn't really the way that was going to work. So they've rigged the system now so that Medicare Advantage firms are paid anywhere from 22 to 35% more for the same person were they in traditional Medicare. So it's not quite the same thing. That doesn't mean that it's a right or wrong choice for an individual. There's a trade-off individuals have to make. So let's kind of walk through that with current numbers. So in traditional Medicare, as I said, 89% of physicians accept traditional Medicare. Fewer accept new Medicare patients because not every doctor accepts new patients, but 89% of adult medicine physicians around the country, not just in your region, but around the country, are available. Almost never do they ask for prior approvals in traditional Medicare. There's a deductible for hospitalizations of $1,600 per time you're stuck in the hospital, and everything you do on an outpatient basis, you have to pay 20% of. So it's not looking so good here. And there's no limit on what the out-of-pocket costs come to. There's no limit to what the out-of-pocket costs can add up to. If you want a pharmacy benefit, well, sadly, that's not included in traditional Medicare as it is in Medicare Advantage. So if you want a pharmacy benefit, and almost everyone does, that's a separate premium. And it doesn't include any hearing, vision, or dental benefits to speak of. So most people that are in traditional Medicare, because of the deductible for hospitals and the 20% copay, most people, north of 90% of people in traditional Medicare, get a Medigap policy, also called Medicare Supplemental. Those are synonyms. So a Medigap is what I usually call it, but they buy Medigap and that pretty much eliminates the copays and deductibles. So, hooray. So what is Medigap? Medigap is a commercial insurance. It's not run by the government. It's run by a private insurance company. There's a menu of these, A through N or something, but you don't need to be befuddled by that. Almost everybody purchases Plan G, G for good. Almost everybody who's looking for Medigap quickly goes to Plan G for good. Repeat that for you. And when you have Medigap Plan G, your deductibles and copays are gone after you've spent $240 on your deductibles. So no copays and no deductibles after the no copays after the $240 deductible. You do have to pay for it. The average monthly premium for a Plan G Medigap policy around the country is just shy of $200 a month, so $2,500 a year, something like that. If that's too much, there is a high deductible version of Plan G available that has all the same benefits, but has a much lower premium and a higher deductible. And none of these Medigap plans, or almost none of them, add any of the other benefits like hearing, vision, dental, or even pharmacy. So Medigap doesn't do that. A key thing is that if you're going to go into traditional Medicare and you want to get Medigap, you have to do that within the first 6 to 12 months that you're in traditional Medicare. We're going to come back to this point a little bit later. So the choice basically is between traditional Medicare with Medigap and typically with Part D, or Medicare Advantage. So that's sort of the choice in the road. So what is Medicare Advantage? How does that work? It's the same range of services. It's supposed to cover the exact same, anything that's supposed to be covered by traditional Medicare is also supposed to be covered by Medicare Advantage. Turns out that's not quite so true, but it's supposed to be. Plus, every one of the Medicare Advantage plans includes a pharmacy benefit. Most include some bit of hearing, vision, and dental. You can usually get them for, I think the average premium for Medicare Advantage in the US is $18 a month, quite a bit less than the $200 a month for Medigap. So $18 a month. And here in Missouri, it's free. I could find a Medicare Advantage plan with zero premium and get a pharmacy benefit, zero premium. By law, Medicare Advantage firms can charge you copays and such. So remember, Medigap gets rid of your copays for traditional Medicare. Medicare Advantage, you can't buy Medigap, it's precluded. So what law does, though, introduce an out-of-pocket maximum. So all of the copays in Medicare Advantage that you would have cannot go above $13,000 out of pocket total. In reality, most of them, I think everyone that I've looked at, has a much lower real out-of-pocket maximum. So the average out-of-pocket maximum in Medicare Advantage is just shy of $5,000 for in-network care, or almost $9,000 for out-of-network and in-network care combined. So think of Medicare Advantage, if you stay in network, as having about a $5,000 out-of-pocket maximum, and think of traditional Medicare as having no out-of-pocket maximum, but Medigap if you buy it. You can't buy Medigap if you're in Medicare Advantage. You do have to deal with the narrow networks, and the networks can change while you're in contract, and these approvals become a big deal. So this is complicated. Most people don't weigh all these factors because most people can't weigh all these factors. It's too complicated. Instead, people that pick traditional Medicare are mainly attracted to it because they like the idea that they can go to almost any doctor, and they like the idea that nobody's going to get in their way and ask for permission. They don't like the fact that they have to buy a separate premium for pharmacy, and they don't like the fact that it doesn't include these other benefits. And they kind of like that they can buy Medigap, but they don't like that they kind of have to buy Medigap. So it's a mixed bag. Medicare Advantage attracts people because it claims to offer the same services and pharmacy and hearing and vision, yada yada, and you don't have to pay for the Medigap premium. So hooray! But people often decide against Medicare Advantage because a $5,000 out-of-pocket maximum is still pretty high for a lot of folks, of course. And they don't like the narrow networks. They don't like being told this doctor, not that doctor. No, not that hospital. They don't like having to get permission for things. That's kind of how the trade-off works in people's minds. I mentioned that you could only buy Medigap the first year or so that you're in Medicare. So you may hear people say, oh, if you're in Medicare Advantage, you can't switch back to traditional Medicare. That's not true. When you're in Medicare Advantage for a day, a week, a month, 6 years, 10 years, during open enrollment, you can always switch back. You can always leave Medicare Advantage, and you can always go back to traditional Medicare. There is no statutory barrier to your leaving Medicare Advantage and going back to traditional Medicare. But the problem is we think that pre-existing conditions were outlawed. We think the ACA said no more pre-existing conditions. Insurance companies have to sell you a policy even if you're sick. Well, the ACA eliminating pre-existing conditions only applies to people before age 65. It only applies to the commercial insurance. So there's a similar protection in Medicare where if you're in traditional Medicare and you want to buy Medigap, yeah, they can't ask you about your pre-existing conditions. They have to sell you a policy, and they have to do it at the same price that they would sell to anybody else in your community for the first 6 months that you're in Medicare Part B, or it's extended to 12 months if you're in Medicare Advantage. If you're in traditional Medicare and you wait more than 6 months, and then you decide to buy Medigap, you'll be sent a bunch of questions about your health, and you may or may not be able to buy a policy, and it may or may not be affordable. Or in Medicare Advantage, if you're in Medicare Advantage for 13 months and you try to leave Medicare Advantage and go back to traditional Medicare, you can, but there's no promise that you'll be able to buy Medicare, a Medigap policy, and if you can, that it'll be affordable. Unless you're in Connecticut, Massachusetts, Maine, or New York, there's exceptions there that those states have created. So you can, but most people in 46 states, most people really often can't afford to leave Medicare Advantage after their first year. So this is a measure twice, cut once thing. Be sure you make the right decision when you're going into it. Frankly, most people today are in Medicare Advantage. Medicare Advantage is now more than half of people. And the biggest growth is people turning 65 who are kind of used to the idea of the restraints and constrictions that are put in by employer-style insurance. But most of the growth is in people turning 65. I'm going to be telling you things that are troublesome about Medicare Advantage, but we have to understand that most people's lived experience with it is not such a terrible thing. You need to be aware of the challenges when you're making your decision, but people in Medicare Advantage are generally as satisfied as are people in traditional Medicare. So again, I'm making the point that although there are some hazards I think you need to be aware of when you're making your decision, in general, people in both groups are pretty much satisfied with their decision that they made. But there is more to this story that I want to help unpack. So first off, we mentioned that there's extra benefits, and every one of the MA plans in the country today offers pharmacy, and they almost all offer hearing or eye exams and glasses and dentistry and all these other. Many offer these other things. I want to unpack just one, and perhaps I picked that one because my father was a dentist and my brother's a dentist, so dental is important to me. So let's just look a little bit closer at the dental benefit, and it's an important benefit. A lot of people join Medicare Advantage instead of traditional Medicare because they want a dental benefit. So they go into it, and it's a big deal, right? People in traditional Medicare, nearly a quarter of people in traditional Medicare say they can't afford to go to a dentist. Nearly a quarter of people in traditional Medicare say they can't afford to go to a dentist. So offering a dental benefit is a pretty good deal to most people. It's attractive. But yet more people in Medicare Advantage say they can't afford. How can this be? How can this be? Well, first of all, it's an unfair comparison because, as we know, people in traditional Medicare tend to be a bit wealthier than people in Medicare Advantage. So it's not an apples to apples comparison, but it's still an important message because if you're joining Medicare Advantage because you really want that dental benefit, it's not such a perfect dental benefit. First, it's got even more restrictive lists of dentists. There's lots of people with this benefit who have to travel 100 or 200 miles to get to a dentist. And if you don't travel that far, or if you don't go to an in-network dentist, you may as well not have the insurance. You have to pay out of pocket for it, or at least most of it out of pocket. The benefit, a slight majority of the benefits stop paying after $1,000. Some go higher, but the majority of dental benefits through Medicare Advantage only pay up to $1,000 of care. And even for what they cover, they require the patient to pay half of it for literally everything beyond preventive care. They often have pre-existing conditions where you have to wait for a certain period of time, 6 months, a year, 2 years, before they'll cover the care for a condition you had when you came there. This varies from plan to plan, and there's variation from plan to plan on what they'll even cover at all. So it's not a robust dental benefit, but it's something. Medicare Advantage requires prior authorizations, like I said. Virtually every Medicare Advantage firm requires you to get a prior authorization for something, and most require you to get prior authorizations for a whole bunch of things. And there's a partial list. I couldn't make the font small enough to be readable and include the complete list, but there's a partial list. So a lot of the stuff in Medicare Advantage you have to, and this isn't just inconvenient. This is frightening, and it's frankly dangerous. My wife needed to get a CAT scan a couple of years ago, and I called her radiology department, and the first thing they asked me was what her insurance was, and I told them she had traditional Medicare and Medigap, and they said, "What time tomorrow?" Right answer. And then I said, "Well, why do you ask me the insurance? What if I had said Medicare Advantage?" And then they said, "We'll call you back in a week or two because we have to get permission." That week or two is terrifying if you need to get something done. It's terrifying, and it might be dangerous. And I'll show you some examples of where it actually is dangerous. There's a lot of that going on in just the year 2022. There were 35 million prior authorization requests just from Medicare Advantage. 35 million prior authorization requests in 1 year from Medicare Advantage. 20 million hours of doctors and their office staff working on these pieces. Rather have them doing something useful, don't you think? 3.4 million of those 35 million, 10% were denied. 10% of those denials somebody appealed, and 83% of the appeals won. Does that mean that all of these should have been appealed and all of them would have won? No, I think that people who appealed were more likely, thought they had a better chance of winning, but still, that's a pretty high level of appeals being overturned. Why don't more people appeal? The most common reason people don't appeal is because they didn't think it would make a difference. So my message, if you want to get a little tip for tonight, is if you're in Medicare Advantage and your MA plan refuses to cover something that you think Medicare would have covered, do the appeal. If it's really something that would have covered, there's a strong chance that you will prevail. So that's Medicare Advantage, a boatload of prior authorizations, and they really interfere with your care. Traditional Medicare does some prior authorizations. Notice that I'm able to use a much larger font because they only do 3 categories and they're relatively infrequent events. Most of that stuff that you saw before doesn't come up. And this is a key difference between Medicare Advantage versus traditional Medicare. Almost no prior authorizations in traditional Medicare. And if you go into Medicare Advantage, primarily because of the lower premium or no premium, this is one of the trade-offs. You have to get permission for things that you wouldn't have to get permission for in regular Medicare. And this tells us that Medicare Advantage patients are having cost-related problems getting into care. So if you just look across the country, 19% more, nearly 50% more people in Medicare Advantage report difficulty accessing care because of cost. It's not as high numbers, but same kind of ratio for white Americans, higher numbers among Hispanics, and as everything in our country, it's dramatically worse for Black Americans. So Black Americans report significantly more cost-related problems accessing care in Medicare Advantage than they do in traditional Medicare. You're probably thinking, as I was, well, how do you control this for income? Because there are definitely differences here too. And so somebody did that study, and people who are in Medicare Advantage of all incomes, cross income levels report more trouble with medical bills and debts. Lower income, of course, have even more problems with medical bills and debts. The difference isn't as striking, but it's still there. There's a few reasons for the difference not being as striking. Medium income folks are where the biggest differences are for having medical bills and debt. So medium income in this study between $20,000 and $40,000 a year for a family of 2, those folks are the folks who have the most trouble getting with barriers with medical bills and debt. And guess what? Wealthier people don't have this problem because they're wealthier. So that's a difference. Let me tell you about a friend of mine, Lefty, or John O'Rear. He passed away, but before he did, when he was just getting sick, and he was hopeful that he would recover, he and I were going to go on a speaking tour around the country that he wanted to call "I've Got the Keys to the Kingdom." That tells you quite a bit about Lefty. He was pretty funny guy, actually. So 6 months before he turned 65, he unfortunately developed one of my top 10 worst diagnoses, esophageal cancer. And his insurance company, he didn't have Medicare Advantage, but he may as well have. The same rules would apply. His insurance company made him go to a local doc where he lived and wouldn't let him go to one of the centers of excellence. Esophageal cancer, I'm sorry, you want to go to a center of excellence. It's really important. And then he got into traditional Medicare at 6 months, and we got him into tertiary care, and he got world-class care. That's when he came up with this. I've got the keys to the kingdom. I've been let out. He was really pleased about having this, but it didn't work because delaying his care, his definitive care. Who knows what would have happened, because it's a nasty illness to begin with. But I've got to tell you, I remain angry that he didn't get a shot at having this treated, and that's part of why I'm talking to you tonight. Not just Lefty, it's not just him, and it's actually pretty common to have delays in care. If you're in Medicare Advantage versus traditional Medicare, people in Medicare Advantage have to wait longer to get definitive care for cancer than do people in traditional Medicare. Case in point, my wife having to have delay for the CAT scan. Case in point, Lefty having to wait until he got in. So delays in care for getting definitive treatment for cancer. And seldom do people in Medicare Advantage get to use the tertiary care centers. Seldom do they get to use the National Cancer Institute Centers of Excellence for their cancers. Is this important? So what? They have to wait a week or two more. So what? They don't get to go to the best place. So what? Well, so what? They die more. People in Medicare Advantage for these cancers are more likely to die postoperatively than are people in traditional Medicare. And the whole reason you have to wait, the whole reason you can't go to the better centers is because these insurance corporations want to maximize their profits, and they don't care about the mountain of evidence showing that sometimes it literally kills us. So again, though, it's a trade-off. Are you going to get one of these uncommon things? If you have appendicitis, any surgeon can probably do a good job. But where do you get your information? The Senate concluded that there's massive marketing deceptions going on. So you've seen this stuff on the TV, right? All these phone numbers, they look like they're from Medicare, but they're actually not. These phone numbers look like they're Medicare, but they have nothing to do with Medicare. They get you to an insurance agent. You might get one of these in the mail that looks like it's a tax form. So for sure, you're going to fill it out. It didn't come from the United States government. It came from an insurance agent who wants to sign you up for Medicare Advantage, but you filled it out because you're a good citizen and you try to do the right thing. Medicare actually secret shopper called insurance agents and said things like this that are just malarkey. If your drug's not on formulary, your doctor can call the plan and they'll just add it. 80% of the calls that Medicare did as a secret shopper to Medicare insurance agents, Medicare Advantage insurance agents, 80% of those calls were lies. We were inaccurate or insufficient to make the right decision. And you see stuff like this all over the place, ads declaring themselves as unbiased. The insurance agents declare themselves as unbiased, and they are not. So I have a couple of friends who are, I can think of 3 people who are insurance agents who are, in my mind, unbiased, and they will give you honest, diligent, reliable sources. So I'm not here to cast aspersions on the industry. I'm here to point out a problem with the insurance industry for Medicare Advantage. If an insurance broker who claimed that they were independent and unbiased, if an insurance agent sells you on Medicare Advantage, they make $600 from that sale. If instead you say, no, I heard that crazy Dr. Weisbart talk, I'm going to do Medigap, and you worked with an insurance agent, they lose more than $200. They only get $350 if you do that. And they won't work with you on Medicare Part D because there's not enough of a commission. If on the other hand, then when they renew it, every year it renews. And if you haven't stepped out of line, if you haven't done anything to change it, you are renewed with that broker. And every year that you renew it, they get another $300 for Medicare Advantage and only $160 for Medigap. So they want you in Medicare Advantage, and they are not impartial. There's even, it cracks me up, there's even the National Contracting Center has seminars for insurance agents about Medicare renewals. And they direct quote, top line on their website, if you want to insurance agents, if you want to retire on your renewals, you can't do it with selling life insurance. You have to sell Medicare. They say this. And here's how the numbers work. If an insurance agent retires with 100 clients, they'll get $30,000 a year steady income. If they have 500 clients, and a lot of them do, they'll make $150,000 a year in retirement without working with you until you gradually move to a different insurance agent if you do. Tell me that they're not biased when they're having seminars all about this stuff. So where do you go for insurance, for information? I'm going to give you 2 sources. The first is this thing called the State Health Insurance Assistance Program. And this is This is a national network, federally funded. So there's the US one. Since we have a lot of non-Missouri people, we still talk to you even if you're not from Missouri. This is the national program that's federally funded in every state. And despite being federally funded, they fund sort of the organization of it. But almost all the people that work in one of these ships is a volunteer. The volunteers swear that they are, they sign a lack of conflict of interest. And as far as I know, they really do not have conflicts of interest. And most of them are incredibly passionate about this. They're volunteers. They want to help you. So you can you can reach out to SHIP, you can go see them. You can set up an appointment and go see them. They're nonprofit, they're unbiased, and very private. So that's one way, is with the SHIP. Another way, if you don't want to do it in person, is to go to the website, Medicare.gov. And I'm here to tell you, that's like a spectacular website. I just love that website. So Medicare.gov. It's like Amazon. I mean, it's like a really easy, in my mind, easy to navigate website, Medicare.gov. Or you can call them 1-800-Medicare. All those other numbers you see on TV, they're not Medicare. Call 1-800-Medicare and it's easy, or go to Medicare.gov. And if you want more information, go to our website, healmedicare.org. There's a QR code for it, and you can get a lot more information. There's a survey we'd like you to fill out. You can sign a petition with your concerns, and if you're a doctor or you know one, you could ask them to do the survey. But let's walk through a bit about what happens at Medicare.gov. So you go to Medicare.gov, and that's the welcome screen. And then you hit this button, Find Health Plans and Drugs and stuff. So hit the Find Plans. And then you tell it if you want to have Medicare Advantage, if you want help with a drug plan, what do you want? Medigap? The next screen, the first, click Find Plans, and then click the what do you want? And so first example I'll show you is, let's say we wanted to pick Medicare Advantage, and it's that easy. You can do this on your own. So then I went there, and I have 44, I counted them, 44 Medicare Advantage plans here in my community that I could have picked from, and every one of those 44 are different. So they have this whole list of detail, and this is just the tip of the iceberg, but there's all these specific things that vary in every plan. And so, there's all sorts of evidence that none of us pick really the right one for matching our needs. And of course, our needs change next Tuesday, or whatever. So it's complicated. None of them are the same. Each one of my 44 plans has something different about it. Very confusing. Let's go back though. Let's say that we went to Medicare.gov and we picked the Find Plans Now, and instead of picking Medicare Advantage, we picked Medigap. How complicated is that? Well, I told you to pick Plan G for good, pick Plan G for good, and they're all like this. Every one of the Plan Gs has this benefit design. Every one of them has this exact benefit design. So what I do is I shop for price, because they're all the same. They're all the same. And if the premium is more than you want, as you can see here, it says the premiums for Plan G for me, for a 70-year-old man, that's all they knew about me, ranged from $200 to $470. If that's too much of a premium, they also have a Plan G high deductible, as I alluded to, and it's the exact same benefits, although it has a high deductible, $2,800 deductible, much lower than the Medicare Advantage deductibles or out-of-pocket max, but $2,800 deductible, and then the premium is about $50 a month. So you have options in Medigap, and then you still have traditional Medicare. So very last thing, and then we'll go to questions if you like, is to please. This is Consumers Council of Missouri. We're not a robust. We're just a group of people trying hard to help people in all the ways Sandy told you. And if you like this conversation, please feel free to click on that QR code or go to moconsumers.org.